imagine. It's every little subtle thing. And so I just try and go through how we think of it and trying to think about it from more your perspective, try and do some of the simple things and pick out and tease out some of the subtleties or not so subtleties of a lot of it is just children walking. And so it's mostly deformities of the lower extremities and things like that. And so that's what we'll talk about today. I'm one of those people, please stop me, throw something, like raise your hand, scream at me. If I am not making any sense, if you can't hear me, whatever. Unfortunately, 10 years into practice, I still have no disclosures, unfortunately. So this video doesn't work, but it's funny, I went to Missoula, so I still go back to Montana twice a month. 2 days in Missoula, 2 days in Bozeman, every 2 weeks, and I was in the airport on Monday night and then came back last night. And it's funny as I'm sitting there thinking about this talk, how I'm sure people think I'm some creepo as we're sitting there in the airport, because I just watch people walk and I have videos which unfortunately turn to the side and are totally useless, but it's fascinating how we all get into our line of work and see the world through a different view. So skip those. Thankfully, we ran through this a couple of times. The rest of the slides, I think, work. Some of the switching it to the PC changes the cropping a little bit. So some of them, if they look unpolished, it's not me, it's the computer. So kind of just as you guys do in clinic, I mean, a lot of it is, there's that subtle part of you meet somebody and your sensors are turned on and you're already picking up different things about them without, even asking, what are you here for? So I usually spend a couple of minutes, just chatting with children, because it's amazing, and trying to shut their parents out, as I'm sure you guys do, trying to get to know them and watch how they move and watch how they interact. And there's a ton of information that we obviously get from that. So, when we walk in the room, obviously the first question is, what are they here for? And I'll even sometimes burst in the door and say, what are you doing here? The kids are like, and then I said, don't worry, we don't do shots. I don't know how to do shots. You're safe today. And they all relax. And I had one little 5-year-old once tell me, oh, Mom, can we come back to this doctor every time instead of go to that other guy that gives the shots? It's like, yes. So establishing the concern. And this is usually, when I turn around from the kid, this is usually what I see, and probably what you guys see too. It's not just mom and the little kid there. It's like grandparents, next door neighbors, people they don't even know, who all are been watching this kid and have their own concerns. And a ton of deformities are driven by grandparents. And I think it's because we've changed how we treat malalignment and deformities of the lower extremities over the last 50 years. And so the grandparents have a child or a sibling that was treated in casts or braces and things like that. And so they're sure that the kid needs, something like that. And for very good reasons, we don't do that very much anymore, as we'll kind of talk about. But for knock knees, I was one of those, I'm not supposed to leave the podium, which really sucks. I was a knock-kneed little 4-year-old, and my mom took me to the guy, I grew up in West Yellowstone. My mom took me to the doctor in Idaho Falls, and I got braces, which was not that much fun, as you can imagine. And then I got into orthopedics and learned about all these studies that have since been done, found out the braces don't do anything. But she saw me get better in the braces, and so she's sure that, as are these grandparents, that it was the braces that made people better. So trying to understand that perspective is obviously really important, because sometimes the question that the kid has is very different than the question that the parent or the grandparent has, as you guys all well know. So, and then just, looking at history, believe it or not, I ask about other medical issues, the history of the pregnancy, birth, and then the initial development of the kid. One of the big ones, especially thinking of pregnancy, are packaging issues, which a lot of these little kid things are, some are not. And so thinking about those are obviously very important. And then trying to remember back to what's Tay-Sachs disease and all these things. But I mean, we end up seeing a lot of those kids. And so it's just keeping in mind all those different issues. Here's a little kid that's got a little bit of spasticity. Here's a kid with Tay-Sachs disease. So, we're trying, and thankfully, usually they've been to somebody else long before they got to us, so I can read the history. But a lot of those things are very important, metabolic disorders, rickets, things like that. We get kids that come in for joint pain, and a certain percentage of them have a rash that seems to be related. So unfortunately, we can't just focus on the feet or the knees, which is what we really like doing, but that stuff's really important. And then obviously, as you guys know, at least as well as I do, a regression of milestones is obviously a huge red flag, and not to be ignored. And then thinking about family history too. If the mom said, oh, I was a W-sitter when I was a little kid, or hey, I'm still pigeon-toed, or things like that. Because the longer I do this, the more I realize that a lot of these things are genetic. So femoral anaversion is definitely genetic, as are a lot of things. So looking at milestones and just keeping track. So, certainly the biggest complaint that if I had to list chief complaint, it'd be like tripping, and so, you see these little kids, and she walks pretty well, and they trip once in a while, and so it's hard to perceive, and sometimes nowadays parents bring in videos of their own, which doesn't speed up our efficiency any, because they can't find it, and then they have 3 videos that are each 20 minutes long. But I mean, it is helpful, videos, and 90% of these videos I stole off the internet, because one of the cool things is, man, it makes making talks easier, and you can find all these crazy things on there. So we, ask about pain, limping, tripping, and falling, things like that. Obviously one of the big ones that we think about in little kids and little boys is, can they get up from a standing position? Like here's a video of the Gower sign for a child with muscular dystrophy. Those are things to keep in mind. And I'll go through in a second, like the basics of the exam, and then just a bunch of different things that we see. Ask them about aggravating factors. A real common one, like our daughter, who I have a video of here, she does great in the mornings, but as she gets tired in the afternoon, then they can't compensate as well. So asking questions about that, does sleep make it better or worse? School. I have probably, a very small but certain percentage of kids that it's not an orthopedic problem, it's a school problem, as you guys see, I'm sure, a lot more than us. Is it episodic? When does it happen, et cetera, et cetera? Is there associated pain? And one of the, I think, really distinguishing factors is how much pain, which is hard. The pain scale is, hopefully we all agree, is almost wordless, in that it's really as much here as it is here. And so I had a kid yesterday with a herniated disc up in Missoula, and it was in horrible pain, and we've tried 2 injections, and finally yesterday I asked, so what are you still able to do? He's like, oh, I play basketball 6 days a week, games on the weekends. Like, okay, wait a second, I clearly had this misread, and I mean, if you can still play basketball, 10 hours a week, then I was thinking, you were lying on the couch about to die. So those things are all important. Sitting habits, I skipped that one. That's a really common one. Our daughter Claire does that because she has femoral anaversion. So just trying to ask the parents, but a lot of it really is just watching the kid. Gotta flip through these faster. Again, back to just looking at systemic issues, especially in little kids, you can't ever rule out NAT, and maybe it's, at school, things like that. And then, limitation of activities. If they're sitting on the sideline, that's a lot different than this kid that was playing basketball, practice 5 days a week and a game on the weekends. So exam components, which I think this is where hopefully this will be helpful to you. All the previous stuff. As I talked about earlier, they walk into the room, or I walk into the room, and you're already paying attention from the word go, and so you're looking at how they're sitting on the exam table and seeing what they're doing, seeing how they're interacting with their parents and or their siblings. It's all the little things that you can't really put into your note even about, how is this kid's cognitive development, speech development, let alone motor development. So it's looking at all those things, asking the parents all those questions. And then when we really go to the exam, a lot of it for us is walking, and sometimes I'm able to go with our daughter Claire to the pediatrician's office, which is fascinating just how differently we do things. One of the big differences is, like, I always have the kids walk in the hallway, which doesn't speed up your efficiency any, but at least for an orthopedic exam, is very important because it's really checking out how they move. And so we, this is off the internet and obviously not in my office, but, it's having them walk up and down the hallway a couple of times. When you look at her feet, it's like, oh my gosh, that looks very different than when she's sitting. You know, she's up on her toes and her feet are curving in and things like that. So I have them walk, and sometimes it's 3 or 4 times just because my body is not good at multitasking, as I've read most males aren't. Women could probably do this once and get it all, but I have them walk 3 or 4 times because sometimes I'll look at their head, and then I'll look at their trunk, and then I'll look at their knees, and then I'll look at their feet, because it's hard to, and then you try and put it all together, but it's you know, even Alan Stotts, who's like the gait master, you know, you just can't get it all in one trip down the hallway. So I then have them walk on their heels and their toes, you know, just to see how good is their balance and coordination, plus how tight are their gastrocs. If they can't even get their toes off the floor, well, their gastrocs are tight. But I'm also just looking at their overall balance and coordination and things like that. The next one totally didn't work. The clips shifted. So I have them walk on their toes, again, looking at balance like that. I then have them hop in place. You're not in my office. You know, have them hop on one foot, you know, and obviously a 3-year-old's going to stumble and fall a lot, but it's kind of putting that into perspective. If he can't do it at all, that's different than if he can do it clumsily or do it very well. And then I have them squat, you know, just do a basic squat just to kind of see how good is their core muscle strength and their proximal leg muscle strength, balance, and coordination. And then this is a short video of, I take them back into the room and, you know, check them on the exam table looking at, you know, muscular flexibility, joint flexibility. But one of the ones, I gave a talk a couple of years ago, apparently I'm the most recent orthopedic guy to give grand rounds, which is a shame because that was 5 years ago. But one of the things that I had in my talk before was looking at rotation, and so there's a video that I think really well.
The next step in the rotational profile is to measure hip rotation. Remember that hip rotation should always be symmetric. We're going to measure hip internal rotation by dropping the legs out.
So you have them lay prone.
0 degrees would be straight up, and 90 degrees would be the feet touching the table. So with the pelvis level, we check Nico, and it looks like he has internal rotation to beyond halfway or beyond 45 degrees, and I'd say it's about 50 to 55 degrees of hip internal rotation. We measure hip external rotation by crossing the feet. And again, 0 straight up and down, 90 degrees would be the feet hitting the table in a crossing pattern. And I think Nico has about...
I don't know if you picked it up, he says they should always be symmetric. It's amazing how many kids are off by about 10 degrees. So it's not a catastrophe. My legs are off like 15 or 20, so I run like crazy weird. And I was the egg beater in track, which I did 1 year in high school and came in dead last every single time. So skip that. So checking them just to see how far they go. Is it asymmetric? And kind of the limits. So if they dropped, and I've got some pictures later on, if they drop clear to the exam table, well, that's a lot of inward rotation. It should be pretty even. Little kids have a little more in each direction than adults, but about age 10, you should go 45 and 45. So, and that's looking again at the femur. And really you're looking at hip range of motion. So if they had some really crazy, weird hip thing, your exam could be skewed, but it's pretty
40 degrees of hip external rotation. And this is completely normal, and Nico should be fine with this. If Nico had severe to assess
looks next
at the thigh, foot pointed inward in external rotation.
Tibial rotation. So tibial rotation.
So long axis of the
you look down at their 5-foot axis. Video. And that just tells you about
thigh and the long axis of the foot, and these should line up fairly straight in a child without any internal or external tibial rotation. If you had internal rotation, it would look something like this. External rotation would look something like this. We also try to estimate the degrees, and we can look at the right side for that. We look at the long axis of the thigh and the long axis of the foot, and there does appear to be external rotation, exactly as we saw in the foot progression angle. I would estimate this at about 10 to 15 degrees or so of external rotation, all completely normal and fine for Nico. from the prone position, we can also look at metatarsus adductus, another cause of in-toeing. We look at the lateral border of the foot, and this should be very straight, exactly as Nico's is. If he had metatarsus adductus, we would see the lateral border curved, something like this, which I'm simulating.
And there's a link to that at the end of video. So again, things that we're looking at, it's like, I mean, there's a bazillion things you got to look at. You got to look at different aspects of their trunk and their upper extremities. You know, if they have hemiplegic CP, they're going to posture on one side, and are they swinging their arms? And then we're going to talk about lower extremity and a couple of things on the right. But obviously there is a bazillion components, and even after 10 years of practice, I feel like I'm starting to get the hang of it. So it's tricky, and that's why we're here. But it's nice to know at least the basic concepts that we're looking at, so that you can start thinking about it in your office, or think about it more often. So I kind of break it down rather than looking at all those things, because it's kind of hard to just say, okay, let's look at trunk swing and what does that mean. I think it's more useful to look at them in terms of like a kid with genu varum, and this is what they look like. So the talk is kind of designed around that. And so first we'll look at genu varum, which is, we're all born, and there's some graphs in here too, we're all born with genu varum, and it's part of packaging. To fit inside mom, we have to be really curled up inside. And so this is what little kids always look like when they come out, but we should grow out of it over the first year or two of our life, and then get knock-kneed, and then that should go away. So if it's persisting, especially, this kid's probably 18 months old, and it's frequently associated with inward tibial torsion, as you can see, especially on his right side. We call it Blount's disease. You can just call it genu varum. It means the same thing. And in the next slide is our daughter. She also has metatarsus adductus. And Amanda had oligohydramnios in the last month or so. So she had a dislocated hip. She had bowed legs, metatarsus adductus, inward torsion. But it's all getting better. She obviously needed a Pavlik harness for the dislocated hip, but most of the rest of the stuff just resolves on its own. I had a family come in a couple of weeks ago, and it was just clear that we should get an x-ray because they didn't believe a word I said, even though I was the expert from Salt Lake City. So we get an x-ray. It's relatively cheap, and it's really low radiation, even though it's of her pelvis. But today's x-rays with the digital format are way less radiation than they used to be. And so I think it certainly helped these people, and it does frequently, to get an x-ray so that the bones look normal. So that's more than anything that I can say to them. So again, back to what I was talking about before, we used to brace this. We don't anymore. It's completely worthless, and it's obviously a massive nuisance. We used to brace knock knees too, and it doesn't work for that either. So like here's a picture of our daughter. And one of the other things that I had to become a parent to recognize was how asymmetric little kids are. Like, I remember thinking to parents, like, oh man, then you have a kid and you're like, oh, Toledo, she's really asymmetric. Her left foot turns in more than her right, and when she was crawling, she looked weird, and like, my wife is panicking because she's in medicine, and she clearly thinks I'm an idiot because I'm not doing anything. And so, like, kids are asymmetric is what I learned from having Claire and having a child. And again, it's our job to then help, feather out, is that okay or not? So if you look at this graph, varus is on. We're all born with varus, again, a packaging thing. And then you should resolve by between 1 and 2. I send all those parents away that have it in maybe an x-ray or not, and say, come back at 2 if it's not, mostly better. Mostly better. It doesn't have to be completely better, at least heading in the right direction. If that graph is staying, flat and heading out, well then, like this little kid, it can persist afterwards. Like this guy, he's like 4, and it's like, holy smokes, that's not okay. So then we jump in and do something. And again, we don't do braces anymore because they're completely worthless. A lot of times those kids will get an x-ray and look at it. And we've got this classification scheme to like look at the proximal tibial metaphysis and help us decide, should we intervene or not. And then if we do intervene, we put in these little brackets on the growth plate. So you take somebody who is, just not getting better, and you probably should use the mouse and then they can see it online. We put this plate and 2 screws around the growth plate, and it stops the growth on this side and allows this side to keep growing, and then they just grow straight, which is way less fun to us than an osteotomy, but way more fun for the kid and their parents. So the old-fashioned osteotomy was, just cutting the bone and straightening it out, and obviously that's nice because it happens very quickly, but obviously it's way more invasive and way much more of a nuisance for the parents to take care of a kid who can't walk while they're healing. So we don't use osteotomies very well unless they're just not getting better. So then they're supposed to grow into genu valgum, and then that usually fully corrects by about 7 to 8 years of age. If it doesn't, how much they have left really kind of boils down to, as you see there, like a lot of times it's cosmetic and it freaks parents out, and so then you're trying to decide how much it is, and it really takes a lot of genu valgum to have pain in a young person, but we're then trying to predict, is this enough that it's going to cause arthritis, which is certainly not well established exactly when they get it. So if they don't improve by age 8, and I kind of tell the 4-year-olds, like, well, you can come back by age 8, as long as it's not like asymmetric or crazy amount. The bracing doesn't help. I found this online as I'm searching around. Strapping, you wouldn't believe what's on there about strapping and things like this. It doesn't, it's the shape of the bone, and so doing things like this is not going to change it. So Dr. Stevens, my senior partner, invented this plate. We used to use these staples that were prone to backing out because the physis wiggles a little bit, and so with a little bit of wiggle, every time the kid's running around, the staple backed out a ton. So if you put 2 screws in there, they just don't back out as frequently. So you put the plate in there, and then you can see, as I was talking about, it just helps them grow straight, and it works really well, and it works very easily. And sometimes I end up getting kids that never from this region, only Montana, who the well-meaning primary care doctor said, go see him when you're done growing. And it's like, oh my gosh, like this is way easier than this. This is more fun than this. But again, it doesn't matter if I'm having fun. So we don't wait till they're done growing. I say if it's not corrected by 8, come and see us. It's easy for the milestones in girls because you really need to start correcting it about menarche because then you have about 2 years of growth left. So I tell some families, like, she starts having periods and she's crooked, bring her back, because that's about enough time that we can correct it, because it takes anywhere between a year or 2 for those plates to work. So things to like raise alarm, like I have an x-ray of even one of my kids, if they're asymmetric, really asymmetric, a little subtle asymmetry is okay, but then like something's not right. And so, x-rays, they don't hurt, they cost a little bit of money, getting low radiation. So this is a kid with rickets, and the first stop is endocrinology. It doesn't matter how crooked they are, because it is amazing how well kids can correct with calcium and phosphate supplementation. So we always send them there first. Like this is a kid here that I saw in my office years ago and had rickets. And how you can tell it's rickets, this one's even better, is the physes are widened. They usually have varus at the hip. They have flared metaphyses. They kind of look a little mottled and ratty looking, and they kind of just look like the rest of her bone is clearly not perfectly straight either. So they just have weird looking bones. That's a nice way to remember it. So they just don't look crisp. They don't look healthy. So we send her to endocrine. They put her on supplementation. She got better to here, but was still pretty crooked on the right side. And so we put in these little plates. And 12 months later, she's straight. We take the plates out. And then I just saw her for follow-up like 3 months ago, and now she's like old, 12 or something, and doing great. So it's really simple and really easy if we catch it in a timely fashion. Any question about those? So those are coronal plane deformities. Now we'll go to rotational. All right. Pretty straight. Within a little. We usually measure both by 1 or 2 fingers. You get like 6 fingers in there. And it's obviously standardized only to me. my fingers might be a different size than, somebody who has smaller hands, but nice, easy, quick, consistent way rather than taking around a tape measure all the time. So femoral anteversion, this looks like knock knees, but really, if you look at where her kneecaps are, they're really on the inside. And so rotational deformities can look like coronal deformities, as a lot of these pictures show. And like genu varum, we're all born with excessive femoral anteversion. And that one, sorry to keep throwing different numbers at you, usually resolves by 10. So all these things should kind of get better by 8 to 10 years of age. Flat feet should get better by 8 to 10 years of age. So they should resolve. And if they don't, like this guy's obviously not 10, but it's like, wow, that's a lot of rotation. But we still watch them because the only treatment is an osteotomy. And again, that's fun for us, but not so much for them. And I have a lot of parents ask about W-sitting. It absolutely does not make it worse. I did have a therapist, a very smart therapist recently said, in very young kids though, she's like, I worry about it affecting their balance. Because if they're sitting like this, they're on this nice big platform and they're working their core muscles less, which is totally legitimate, but it doesn't make the legs worse. Because again, it's the bone, and we can't stretch bones longer. That doesn't make any sense. If somebody's short, we don't just kind of pull on it once a day to make it longer. So it's the shape of the bone, and you can't change it that easily. And if they have a little left over, like they're faster. So the story I always tell parents and kids in the office is, if you look at the Olympic sprinters and runners, they're all a little in-toed. To make it that far, you have to have the perfect body. And part of that for running is to have a little in-toeing. So a little bit's okay. And if you're an out-toer, those are the slow people. And I purposely picked this picture because all the people in the lead are a little bit in-toed, and this dude in the back is out-toed. I'm a little in-toed, and again, I'm very slow, so it doesn't guarantee your kid that they're going to be fast. But so in-toers are faster. And again, looking at it, like here's I think a great picture. So this is looking at two femurs and the knees on the top. And so there's the trochlea for the patella, the femoral condyles in the back. So they're kind of sitting on those. And then you look up here at the top of the femurs, and you can see that it's really twisted on this side versus this side. So where is the twist? I don't know. Somewhere between here and here. And it doesn't really matter, because it's one big cylinder. And so when we go to change it, we just cut it in the mid-shaft for technical reasons related to the hardware. It's best to make the cut where the canal is the thinnest so that it doesn't wobble and then cause a displacement of the bone versus doing it up here. Plus they don't heal as quickly up there. And we can do this through, like, the biggest incision is this on the hip. You have to make a poke hole for the locking screw up here, and there's one down below. And then, believe it or not, you cut it through, it's really cool. You cut it through a little tiny incision, make this little poke hole, and then you take a drill, and you drill like a bunch of holes in the femur. And then the very cool part is you stick a chisel in there and then whack, and it cracks, and everybody in the room can hear it, and we all cheer and think it's really awesome. And then you put the nail in there, and you put wires in so you can make sure that you rotate it the correct amount. And I had a kid that had a femur fracture from North Dakota somehow that came in 6 months after she had broken her femur, and the guy had unfortunately put her on like 30 degrees off. And so rotation is a really important thing, and so we had to re-break her femur and fix it, and obviously that's not cool. So femoral anteversion is in, femoral retroversion is out. Femoral retroversion really doesn't cause very many problems, but when you watch this lady walk, and obviously she's not a kid, you can see her knees kind of swing out when she's walking. So that's how watching the knees is a great way to measure rotation, because you can see which direction they're pointing. Watching the feet is important too, especially there's one on the next slide. And it's really interesting. One of the things that I've noticed over my career is, and I apologize, this is a really big guy, and I'm not obviously trying to make fun of anybody, but when you watch him walk, he's got a ton of outward rotation. So the really big kids seem to develop, it's causing something on their growth plates, and they develop outward rotation. So he could have had a skiffy or something like that, which also causes outward rotation. But generally speaking, when you're in the airport next, if you're watching people, it's usually speaking the bigger people that are walking out-toeing. We don't know exactly why that is, but the way that it seems to work. And it also requires an osteotomy to fix, but we fix that way less often because it doesn't seem to cause as many problems. And again, we're just getting them up on the exam table and checking them like we were in the video. And then if you look at the tibia, it can be rotated inwardly or outwardly. It's usually inward in little kids and outward in older kids. And so like here's that guy's knees are pointing straight ahead, so it's not femoral retroversion, but he's rotated somewhere in the tibia. And again, to us it doesn't matter where. We think it's somewhere in the mid shaft. There he tries to correct it, but it turns in his kneecaps. And again, probably like I did a tibial rotational osteotomy on a 9 or 10-year-old kid a month or two ago. Because he's just achy, sore, he's slow, and really it's pretty easy to do. Again, that's easy for me to say, but back to the pictures. See, this guy's losing, this guy's winning. We used to do them like this, but that puts people at a pretty high risk of compartment syndrome. So now we go right above the ankle and just cut the bone, and then you rotate it and just put pins in, which we take out in the office. And yes, it's like having a broken ankle for 6 weeks, but they recover really rapidly, especially if you do it, before they're 30. And so it's not as bad as it sounds, and it's very effective in correcting them. Probably the biggest downside is you don't want to do both at the same time because then they have to be lifted to the toilet and everywhere else and be in a wheelchair. So we usually do them one at a time. You can then have a combination. Again, I found this on the internet. Some girl like, hey, does anybody know what's wrong with my legs? So she obviously looks very knock-kneed and wonky, and she we call it circumducting. Her knees are so in that she has to swing her legs around to walk. So she has femoral anteversion and outward tibial torsion. So they're rotated in the opposite direction. So she walks pretty well with her feet. They're a little bit inwardly rotated, but not nearly as much as her knees. So her thigh bones, her femurs are inwardly rotated, and then she has some compensation, not purposefully, in the tibias. And so these are the kids that have the most trouble. Like usually they end up getting treated. So at minimal, they have a lot of knee pain. But I had a kid yesterday, Missoula, who a week ago dislocated her kneecap because I apologize to the people online, but so I have this. When I bend my knees like this one did, and because this one, her kneecap wants to be was always wanting that way. And in girls especially, where they have more ligamentous laxity, and they get bumped or something in basketball, it dislocates, and then it's just persistently unstable. So you can do an MPFL, the ligament there, repair, but it usually gets stretched out over time. And so it sounds totally nuts, but in these kids, we usually end up doing a femoral and a tibial rotational osteotomy. And the nice thing is they heal at the same time, so it's the same healing time as doing them alone. And it works really well. And so those are the ones, but to watch for, because especially, it looks like she has knocked knees when she's walking, and it's really not. And so you get her up on the exam table, and she's one of those that her legs would go clear to the table. They would rotate inwardly 90 and outwardly maybe 10 or 20. Questions about those? Speed up. Club feet. Obviously, it is a gait abnormality, except we catch them so early that it's not. So club feet is a combination of cavus, adductus, varus, and equinus, cave, and it's not a packaging issue. If it is a packaging issue, it goes away on its own very quickly, and they're way more flexible. I had a kid yesterday in Missoula that had a positional club foot, and that's going to go away on its own. And you can just tell by how flexible it is, which is really hard to obviously convey. But so send them all, but if it's a true packaging issue, it goes away on its own. If it's a true club foot, like even their calf muscle, even in this little baby, you can see his calf is smaller. So we think it's a neurologic issue that's then affecting the muscles and telling the muscles to do crazy things. And so assessing the flexibility is the key point, and then we've got the treatment down below. But if you don't fix them, which obviously they all get fixed now, I mean, that's what they turn into, and I've got a video here of some guy from India who... Sorry, I tried to shut that off before. But I mean, if you watch him, I'm going to rewind this a little, his foot is backwards. I mean, it's pointing backwards in that picture. There you can see it. And they still wear usually in third world countries, you see them wearing things like sandals or like a rubber tire strapped to their foot. And I mean, that one foot is pointing backwards, and he kind of slowly walks by, and you can see that left foot is, I mean, obviously people here never have that trouble like that because we catch them early. And so when we catch them early, we just do this series of casting, and you just slowly correct the foot. And I had one parent who one time said, can we stop now? Because I want our kids actually their feet to be pointing straight, not out. And I had to explain, we shoot for the normal flexibility in kids, which, you know, you then take the other foot and say, see, it goes clear out to the side. So we correct them past neutral just to get their normal flexibility. They almost always need tenotomy of their Achilles because that doesn't stretch out as well as all the other components, unfortunately. And that's what the casts look like. They're a nuisance because they go clear up to the diaper, so they always get pooped on and peed on, and I always tell the parents that's my fault. We just have to do it that way. We leave the toes out so that they can see them and call us if they're panicking. And then you just every week serially cast these kids 4 to 6 times, and then with the last cast in the office we do an Achilles tenotomy, which sounds horrific and brutal, but you put some Emla cream on there, numb up the skin, send them to lunch, have them come back, we inject through the numb skin with a little bit of lidocaine with the parents in the waiting room. And then just with a little tiny 15 blade, you poke through the skin and just twing, and then you put them in a cast and it grows back in 4 weeks and they're good to go. And then because it's a neurologic issue, we put them in these braces that hold their feet out until they're 3. The first 3 months, 23 hours a day, and then at nighttime. So, I mean, it's a big deal because if you don't use that, the neurologic issue brings the feet back in and they recur. And then it's way harder to treat when they're less flexible. But like in your office, like it's easy to pick up a club foot because it's so crazy. So here's like a video of, like this girl has some cable hairs, like not all cable hairs are dates, and so like you can see.
Now turn around.
Not as bad as the Indian guy.
Go back now.
You know, they're still pointing in and pointing their toes because she's got them trying to contract. So, but it's still, you know,
Again.
walk up and down the hall a few times, and usually you can see it pretty well. So club feet have metatarsus adductus, but you can have metatarsus adductus on its own without the equinus. Obviously, this kid can get his heels on the floor. It doesn't have any cavus, which is a little hard to tell from this picture, but that we think, like in little Claire, is a packaging issue. You're squished in there, oligohydramnios, twins, whatever. And I had a mother yesterday that had a bicornate uterus, so it was thought that might be, the one foot was caught. You know, seems a little weird thinking of like, anyway. So you assess the flexibility. If you can get them back to neutral or past, which almost always you can, then they get better on their own. Despite my wife asking me almost every day, are you sure? She's 2 now, it's not all the way gone. Stretching here's a little video of a guy with it. He was pretty excited there. We usually wait and don't treat it. But that being said, 10 years into practice, I've gotten way more aggressive. Wearing shoes on the wrong feet doesn't hurt. We don't think it helps. The shoes mold to the foot more than the other way around. But stretching can help. I stretched Claire twice and then just said, we're going to watch it. It seemed like a nuisance. But I think a lot of parents do that. It's like, tell them, oh, just stretch. And they're like, yeah, okay, right. So more often now, certainly not all of them, it kind of more depends on the parent. I say, we can get it better a lot faster if we just cast them. This is what the cast looks like. If you're willing to do that for a couple of weeks, we can cast it. And because the downside is so low, I probably cast more now than I used to. And then for the families that really want to torture themselves, you can use the same clubfoot brace that just holds their feet out and it's rigid. But the problem is that probably takes a year to get better. So I kind of, if they're the family that's just like, can't wait, which happens, then, I offer them casting. This isn't a gait abnormality, but it's a really common thing, curly toes. And so we see a lot of questions about curly toes, and this is a little video that's too long, but, there it is, curly toes. So curly toes are when the flexor tendons are too tight. It's not toe number 2 that's the problem. It's toes number 3, 4, and 5. The flexor tendons are too tight, and I always tell people that the second toe is the lazy toe, and so it just flips up over the top of the other ones. And the big toe is very, very rarely involved. But yeah, it's curly toes. These things totally don't work. So braces and orthotics don't work. You can just stretch them up into the outside. I always tell parents to do that first. And a lot of little kids have them, and it seems to just get better with time. The problem is if it doesn't, and they can go the other direction as well. If they don't get better, like the treatment, this is the bottom side of the toe, you go in and you just twing all the tendons there's 3 little slips of the tendon. So you can just cut the tendons and then it looks beautiful. The problem is then they don't have a whole lot of toe flexion, which is not that big of a functional issue, but for the ones that don't get better, that's what we do. You just go cut those 3 little slips. Those are not nerves, those are just tendon slips, and then they look great. Flat feet's another common one. All infants have flat feet. And some people say, obviously it's difficult to know, that the fat pad might be protecting, these little kids running around in bare feet. Not sure that's really what it is. But you should develop arches by 10. And at 10, you're where you're going to be. Another picture, or another video again. You're going to be where you're going to be. In 10% of the world, and one of the things that you can notice in this video is, like, he plants, but when he goes up on his toes on that left foot, you can see that he develops an arch. And that's really the critical thing to us that matters. That tells us that they're flexible. He squashes his foot down flat as a pancake, but then his arch comes back. So that's an okay flat foot to us. Arch supports and orthotics don't help your arches develop more quickly or better. If you took a kid with flat feet and you put one foot in an orthotic and one not, and then watched them 15 years later, and you took out the orthotic, they would look exactly the same. They're kind of like high heels. You look different while you're in them and function differently, and that might be useful for various things we'll talk about in a second, but it doesn't change your height permanently to wear high heels. And orthotics won't change the arch. But they are very helpful. Like, this is a little kid with Down syndrome, and Down syndrome children have the loosest ligaments on the planet, and so they have the flattest feet on the planet. And sometimes it's a functional issue, and so like this little guy, his feet are so flat that he kind of sinks, and he's unstable, and he uses his toes to try and correct his foot alignment and things like that. And so if you put these kids in orthotics, oh my gosh, they function way better. And so that can be really helpful. So we're not against orthotics. There's here in the audience. You just have to explain to the parents what, if they're looking for you to make the arch better, and they're functioning fine, it doesn't quite work that way. But they can be very helpful for those kids that are unstable or weak, because they really do change the foot position. And then as they get older, so if they're part of the 10% of the world that doesn't grow arches, which I tell parents is way more frequently than red hair, and they both have a worse name than they really are. They cause fewer problems than most people say. But some people with flat feet really don't. They really help. They really hurt. So if they don't hurt and they're functioning fine, I tell people to quit looking at them. Not always just like that, but if they're functioning, affecting function or causing pain, then we usually do something. They're frequently associated with gastroc tightness, but to truly correct the flat foot requires a calcaneal osteotomy. We go in and cut the calc right here, you lengthen it about 1 centimeter or so, and magically the arch comes back, which is really cool. And then we usually, in older people, use a plate. In kids, we just put a pin in there that comes out in the office. And then it heals, and the left side has not been done. The right side, looks significantly better. But more importantly, it's how are their symptoms. It's like I care how it looks, but much less are they in less pain. And the good news is it's a pain-relieving procedure. But I tell people that this procedure puts you at a pretty consistent pain level of 1 forever, or at least on a consistent basis. So if you have a pain level of 10 when we start, that's awesome. But if you have a pain level of 0, well, then suddenly that's not so awesome. So painless flat feet, we really try not to do anything about. Again, they almost all have gastroc tightness. Sometimes you can get the pain to go away just by stretching the gastroc, and sometimes just by lengthening the gastroc if it's really tight. To lengthen the gastroc in not infants, we go in and make 3 little cuts. You just cut it, and then you stretch it out. So 3 little tiny poke holes. In older adults, you'll usually cut it and then suture back together. But in little kids, usually you just make these 3 cuts and put them in a cast for a month, and then they do just fine. And then if they have a rigid flat foot, so if you lift up their first toe and their foot stays flat and they don't have subtalar motion, that usually is suggestive of a coalition, which is this abnormal bony connection between the bones, and it can either be between the talus and the calc or the calc and the navicular, and it actually can be other places, but those are the common ones. So, and that's a developmental abnormality from I think it's 7 or 8 weeks of gestation when you formed your skeleton and then your femur separates from your tibia because it started out as one chunk, and then all your little foot bones separate from each other. And if they don't fully separate from each other, then you can have a coalition. And if it's a little coalition, we'll go in and take a Dremel tool and drill this out so that we haven't messed up the rest of the joint. But if it's more than 50% of the joint, then we just fuse the rest of it, do a subtalar fusion. And that's usually pretty effective. And again, the test to look between the two is lifting up their first toe. If they make an arch, that's a good sign that they have they don't have a coalition. Did I stop for questions? I just have this is a good one. Limb length inequalities. This is another one that you're going to see it today that I think is really important to talk about. This girl has a huge limb length inequality, but we'll talk about the issues as we're watching it. 7 millimeters is the average. So not just normal, but that somebody did a study looking at a couple hundred of military volunteers and found that 7 millimeters was the average limb length difference. So 2 millimeters is not going to cause a problem. And when you think about that, we start out as one cell of a limb bud at day 1 of limb bud development and go to them being 2 to 3 feet, more often 3 feet long, and that they end up even anywhere close is really amazing because they're not talking to each other saying, hey, how long are you, or are we staying even? And so it's pretty fantastic that they end up within, 1% of each other. And so our bodies are really good at compensating for, up to a certain degree. So less than 15 millimeters, we really try to do nothing, maybe a shoe lift. Even less than 15, I try and talk them out of a shoe lift, at least initially, because then they get focused on, I need my shoe lift, I need my shoe lift. And it really doesn't usually cause any troubles. If they're having troubles, obviously, then that's different. But once they get to 15 to 20, and definitely after 20, we think about treating them. Because especially over 20, we think then they end up with long-term back problems and hip and knee arthritis and things like that. So options, conservative, again, you can use a shoe lift. Up to a 1 centimeter lift, sometimes if they have a 2 centimeter difference, or say 15 millimeters, you can partially compensate with in the shoe lift of 1 centimeter and get it down to 5. But over 1 centimeter, their heel comes out of the shoe pretty consistently, and so you have to add on to the bottom of the shoe, which sometimes we do in kids stalling to do their definitive treatment. Surgical treatment, it really boils down to shortening or lengthening. If they're still growing, we try and do a growth arrest and put the little plates on both sides of the growth plate and allow the other one to catch up. And if it's 25 millimeters, an inch difference, that's probably not worth it that the kid to do a lengthening. They're going to be 5'11" instead of 6 feet or whatever. So shortening is usually way easier. And again, back to the oh my gosh, it's way easier to correct before they're done growing. Once they're done growing, then you just have to either subtract or add, which again is cool for us. But if it's a pretty small difference, then we'll just chop out a chunk of the femur and then put a rod in there till it heals. If it's a big difference, like this girl had a neuroblastoma as an infant and her treatment left her with 2.5, almost 3 inches of difference, and so in her femur. And so in those kids, typically will lengthen, which over just the last couple of years, there's this crazy cool technique where you put in this rod that has this really expensive $17,000 magnet in there, and then they hold on the outside of their leg this other crazy magnet that spins the one on the inside, and it's got such tiny gears that it's powerful enough to then slowly lengthen it. And we lengthen a millimeter a day. So surgery, wait a week for things to kind of calm down, and then every day we lengthen it a millimeter and keep going. And believe it or not, the bone grows back in there if you do it slowly enough, which is nuts. But you know, we used to have to put external fixators on there and do all kinds of crazy things. But this technique, this device has made things a heck of a lot easier. And then, so CP is obviously complicated. And so I have a little video, just the next slide is the last slide. Like, that's really hard for me to say, oh my gosh, what's going on? So it's really looking at concerns, because you can't make this guy walk normal, but you can help him walk better, which sometimes is hugely important. And so we look at them on the exam table, we watch them walk, and then if they're really complicated, we get a Gait lab, and this is a quick...
You go into the blue room. These are the cameras our experts use to make the movie. And these are whole body moves when you walk. If you use something to help you walk, like braces, a walker, or crutch, how your whole body moves when you walk. If you use...
You know, they're watching her walk by, and she's got all these electrodes on her legs, or markers on her legs that are then picked up by the cameras, and then electrodes stuck to her leg, not into her leg, that measure which muscles are firing when, and you can break down their gait into like the individual components. That's then very helpful to decide, should we do a hamstring lengthening, or will that actually make them worse? You know, all these different things. And so
use something to help you walk, like braces, a walker, or crutches, you will use these in the Gait lab. Then you'll walk between these blue lines as the cameras make your movie. The physical therapist might ask you to walk on your tiptoes, or maybe your heels. Or you might hop, jump, walk backwards, or run. If you need to take a break, just say something. The physical therapist won't mind at all. Then, the physical therapist will put about 20 small stickers on your legs. The stickers listen to your muscles and help the computer make the movie. Then the physical therapist will wrap this elastic around the stickers. It only sticks to itself and holds the stickers on your legs. Sometimes they put this KAD on. They use this at the beginning, but you won't have to walk with it. Let someone know if anything is uncomfortable, and they will help you. Your job is to stand very still while the physical therapist makes sure the stickers are in the right place. Now that you have all the equipment on, it's time to make the movie. You'll stand on this red walkway so the computer can take pictures of you standing still. Then you will try to move your legs while the camera captures it. Then you walk down the red walkway 4 to 8 times. After that, the physical therapist will take the stickers off. And now, you are a Gait Lab movie star.
And then they take like this massive dump of, you know, data and information and go back and collate it into like, okay, what's wrong? What can we do to help you? So very, very cool thing it's trying. And they really make it as fun as they sound in the movie, so that they can get a good experience out of it and get a lot of good information. So that's all I have. Questions? None. That's either a really good or a really bad sign. Yes, sir. They cover them. Yeah, really well covered. They obviously make us send them to physical therapy first, which sometimes is a nuisance because we know it's not going to get better. But, you know, 6 weeks of physical therapy is at most what they'll require. But I don't think I've ever had one not covered. Yeah. Yeah. Thank you guys.